Good evening, everybody, and welcome. My name is Rose Young, and I'm the Medical Director at the Office of Lifelong Learning and the Physician Learning Program. The Office of Lifelong Learning is committed to providing reliable advice and resources for clinicians, researchers, and everyone committed to addressing the challenges related to diabetes and metabolic disease. Firstly, we would like to acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. Tonight, we are very pleased that Dr. David Campbell will present on the intersection of food insecurity and diabetes. He will use the FoodRx project as an example of a program that may help alleviate food insecurity and improve food access for people living with diabetes. He will also invite you to consider who you might know that might benefit as a participant for the FoodRx trial in Alberta. Dr. Campbell is an assistant professor of medicine at the University of Calgary. He holds an MD PhD from the U of C and completed his postdoc at the University of Toronto. In addition to being a clinically practicing endocrinologist, he is a clinician scientist researching social disparities and their impacts on clinical outcomes. He conducts research that incorporates community and stakeholder engagement, mixed methods, interventional approaches, and knowledge translation with the aim of reducing social disadvantage by informing health policy and clinical practice. And we are very pleased that you're able to join us tonight. So thank you, Dr. Campbell. The floor is yours.
Well, thank you, Rose. My pleasure. And thank you for having me. It's a pleasure to be here with you this evening. I'll just get my screen sharing going. That should work. Can you see my screen? I just want to make sure I don't see the green line around it.
Yes, it looks
good.
Thanks.
Excellent. Okay, thank you. Okay, excellent. So I'll dive right in. There's lots to cover tonight, and hopefully we're able to take a number of questions here at the end as well. As was mentioned, I'm an endocrinologist that practices here in Calgary, and I'm happy to share a little bit about food insecurity with you and how it intersects with diabetes. And obviously, we timed this to correspond with World Food Day, which is coming up here on October 16th. And, World Food Day was established by the United Nations Food and Agricultural Organization in 1945, and it is celebrated every October 16th since 1981. And the objective of World Food Day is to increase awareness of world hunger and poverty and to inspire solutions for world change. And so there are a number of events that happen worldwide, held by governments and NGOs and community-based organizations, to raise the awareness that there are many people in our world and in our communities who struggle to access food. When I went to the FAO's website and clicked on a number of the events that have been registered there, I was surprised to see there was only one Canadian event that registered on their website, and that was actually in Edmonton. So for those of you in the city of Edmonton, if you see the high-level bridge lit up in blue on October 16th, that is the city's way of showing support for World Food Day. But you can see it celebrated across the world. I just have the screenshot here of the Northern Hemisphere, but it's certainly celebrated around the world. And there's many challenges, as you're all aware, about food insecurity and food access in the developing world and low and middle income countries and countries that are struggling with war and conflict and internally displaced peoples. But it's also an issue right home here in Canada, and especially here in Alberta. You may have seen this. This is just from a few weeks back. It was all over the news that Alberta has the highest rate of food insecurity among all the Canadian provinces. And it was picked up by all the media outlets, this particular story that came from a report produced by some colleagues in Toronto. And these are the actual findings of their study. So this is from the Canadian Income Survey and Household Food Insecurity module, where they looked at how many households reported food insecurity across Canada. And you can see that it ranges from 13% in Quebec up to the high of 20.3% in Alberta. It's a distinction that I'm not all too proud of, but one that we must own anyway. And so we can actually see that not only was food insecurity more prevalent or more common in Alberta, but the severity was much higher as well. So that's what we see in this panel on the right, that severe food insecurity in Alberta was 6.3%, which is considerably higher than every other province. And moderate food insecurity is 9.4%, which again is much higher than every other province. And so we had slightly less marginal food insecurity compared to a couple of other provinces, but really at the more severe end, we were even more overrepresented. So food insecurity is a huge issue, and we know that there are many contributing factors to this, including income and inflation and job security and many, many other macroeconomic factors that contribute to this. But we also need to, so as Rose mentioned, that my talk today is focused on the intersection of this problem, food insecurity, with another problem that we're all very well aware of, and that's diabetes. And so we're all aware that type 2 diabetes is very, very prevalent. Diabetes Canada's statistics, from 2019 state that 317,000 Albertans have been diagnosed with type 2 diabetes, and there's at least another 150,000 who don't know they have diabetes. This says nothing about the hundreds of thousands of people living with prediabetes and metabolic syndrome and other diabetic precursor states. And we know that the treatment of diabetes is also tremendously costly to our healthcare system, that diabetic complications such as retinopathy, nephropathy, cardiovascular disease, all of those things cost our healthcare system a tremendous amount of money and result in individual morbidity and mortality at very high rates. We also know that the reason that this is because there is clearly an intersection between diabetes and food insecurity, and that the cost of healthy foods is a major barrier to diabetes management. We're all well aware that one of the cornerstones of diabetic management is following a healthy dietary pattern. We know that many of the healthy foods are those that often get sacrificed when somebody faces food insecurity. We know that people shield their children from the effects of food insecurity, and so when good food is able to be purchased, these are often provided to children in households, and the adults are often left eating the lower quality foods and the foods that are higher in glycemic index and higher in processed foods. And we know that there's a number of data sources that show that dietary modifications alone can reduce A1C by at least 0.5 to 1% through dietary changes. And this certainly depends on the magnitude of dietary changes that remain to be made. I'm sure many of you have seen, as I have, patients whose diabetes has come under dramatically improved control by making dietary changes. So it is a very important part of managing diabetes. But when people face food insecurity, we know this just places yet another barrier in people's way with respect to managing diabetes. So we did a study a number of years ago that we published to say, what is the impact of financial barriers, including food insecurity, on patients' hard clinical outcomes, or the likelihood of them being hospitalized for their chronic diseases? And what we found is that for those who face any type of social disadvantage or financial barrier, they were much more likely to be hospitalized for diabetes or cardiovascular disease. But you see that the estimate that's the farthest to the right is for food insecurity. And those who reported food insecurity were observed to almost 70% more, have 70% more hospitalizations compared to people who were not food insecure. So a very important determinant of outcomes for people living with cardiometabolic disease. We use that data and a number of other data sources to postulate or estimate the excess cost borne by our healthcare system when people face food insecurity and hyperglycemia, which often go hand in hand. And when we look at the Alberta specific data, we see that people in that quadrant who face food insecurity as well as have high A1Cs, they cost about $10,000 per year more to our healthcare system than people who are food secure and have better glycemic control. In Alberta, we know there are 9,600 patients with food insecurity and hyperglycemia. And so when you kind of factor this out, we can see that there's potential cost excess to our healthcare system of over $178 million per year due to food insecurity, just in the fraction of the population that live with diabetes. What we're trying to do in our work is reduce the excess cost of that particular group of patients and help them to achieve food security and thereby improve their blood sugars. So one of the big questions is, what can we collectively as clinicians do about food insecurity when we see it? And one of the first things that I like to teach the residents and students that I work with is the first thing we need to do is recognize it and understand what are the social challenges that our patients face. And this can be done with a number of tools, or there are a number of things out there, but one of the ones that I often like to refer to is the American Academy of Family Physicians. They have something called a social needs screening tool that is meant and has been validated for use in frontline clinical practice and in primary care especially, which asks about a number of different facets of social needs. And one of those is food. And the food security screener here that they use has actually been validated. This is a 2-item food security screening module. And it basically asks if people were worried that their food would run out before they had enough money to buy more, and if the food that they bought didn't last and they didn't have enough money to get more. And when people state that that is often true or sometimes true, that's a clear marker that that household is struggling with food insecurity. So I often challenge my residents and students to employ something like this in their practice to try to understand what is the real social context that our patients are facing. But sometimes people push back and say, well, if I find food insecurity, what can I do about it? And you may recall Wilson and Younger's criteria for screening and when screening is appropriate. And one of those is that there should be an accepted treatment for patients with recognized disease. And I know that this will have affected your practice more than mine in recent days with the studies that have been coming out around colon cancer screening with colonoscopies. And people are now starting to wonder if colon cancer screening actually changes outcomes. And the same could be said about screening for social needs, that if I recognize there's food insecurity, is there an accepted treatment for that particular condition? What is at my disposal to help patients with this? And sometimes I find that clinicians are not comfortable asking questions that they feel disempowered to do anything about. And so what can we do, or what do we traditionally do as healthcare providers when we encounter food insecurity? And a very simple algorithm for me. I'm fortunate to work in a tertiary diabetes center where we have social work embedded. So I actually have the luxury of having a social worker that I can send people to. And I know that's not the case for me here. I hope some of you that work in primary care settings have social workers through your PCNs or other supports. But many of you may not have that luxury. Even if you do, what you may find, and what I find sometimes, is that it is helpful to have social workers, but what they can offer is often still very limited. They may be able to help people get on AISH or Alberta Works if they qualify. They may help people complete their taxes, but at the end of the day, there's a finite list of social programs that are out there to help patients with social needs and with food insecurity specifically. So that leaves us with the food bank, and many of us refer patients to food banks or send patients to food banks. And I think it's just important to realize that food banks are really a stopgap measure that do not actually address the root causes or food insecurity itself. And part of the reason is because of the types of foods that are often provided in food banks are reliant on donations and other foods that are given to them by retailers, and they may not be of the highest quality. This is a photo that was taken by my study participants when I asked her to photograph something about her diabetes. And this is straight out of the box. You can still see the box that she received, this food hamper from her local food bank. And you can see the types of food that were provided to her. The healthiest thing here may be these corn squares, which you can imagine would do a number to someone's blood sugars, but maybe better than the potatoes or the sugar or the fruit snacks or the ramen noodles. So you can see that while this might fill somebody's belly, it certainly is not going to help them as they try to manage their diabetes through a dietary approach that's appropriate for their condition. And this is a quote, not from my study participant, that comes from the literature, where this individual participant said, "A lot of my food comes from the food bank. They only give you certain types of food that don't really help you with diabetes, more or less to go against your diabetes, a lot of sugar and cookies." And while this is an American study, we certainly know that these same challenges exist in Canadian food banks, and this is through no fault of their own, given their lack of resources and their dependency on donations for the food that they provide as well. So, when we think about that, these are the only resources that we traditionally have had at our disposal, and they're not great answers to the problem. So what else can be done? I'm not sure how many of you are familiar with the RIFS initiative, or the Reducing the Impact of Financial Strain initiative, but this is an Alberta Health Services combined with a number of PCN's initiative that has been pilot tested in a couple of places in Alberta, and there's a move to expand this to other parts of the province. It's a complex intervention, but essentially what this is a figure that kind of explains what this means, that there's a partnership between clinicians working with patients and clinics and clinicians working with communities. And in our work with patients, we're encouraged to ask patients what matters to you, and to remove our personal biases and agendas, and to ask about social needs, including if they have difficulty making ends meet, as we just saw. Plan ways to support social needs together, and explore if they've submitted their taxes. And then connecting them to community resources that we've got kind of filling in on this side, documenting those needs, partnering with the community to understand challenges and collective action. And this is a wonderful program, but if you're anything like me, my clinic is very busy, and I can't imagine having the time to explore, what matters with patients. And a way I try to incorporate that in my clinical practice, but we're not well supported to do this in most cases, I find, in the healthcare system. And that's certainly the case in my endocrine practice. I can only imagine it's the case for many of you practicing in primary care, where there are financial demands and time pressures and patient volumes that are well beyond those that I have to deal with. So this may be coming to where you practice, and I think it's most successful when it's done in concert with the whole system and the PCN, and not left to individual clinicians to implement this, because it's quite overwhelming to imagine doing all of this. So it takes us back to here. So what else is there? So social prescribing is another initiative, and RIFS is somewhat a version of social prescribing, but I took this slide from East Lancashire in the United Kingdom, where they've empowered their primary care physicians to prescribe a number of things for patients who might benefit from it. And there are a number of initiatives like this here locally. I don't know if any of you are part of the Prescription to Get Active program, which can help prescribe physical activity to patients. There's also I think in Saskatchewan, they have a prescription to access public spaces and parks that are given by family physicians and primary care clinicians. Places in the UK and the United States have actually gone to prescribing housing or social housing for patients that are struggling with housing instability. There are a number of things that could be prescribed in the same way we prescribe medications or laboratory tests to help our patients meet their social needs. And this is something that is still fairly new in the Canadian landscape, but it has been used elsewhere. And specifically as regards to food insecurity, there are a number of interventions which are classified as food as medicine intervention. And this approach is really designed to better address the problem of food insecurity in clinical settings like primary care, to help patients with food insecurity and diabetes to be able to purchase appropriate foods. And these often include either a subsidy or an incentive program. And there's preliminary evidence in these studies that suggests that these programs may improve diet quality and self-reported health while reducing food insecurity, hypertension, waist circumference, BMI, in a number of communities, including in Indigenous communities, actually, where it's been tested specifically. Notably, one of these is a $40 fruit and vegetable subsidy that was delivered to 65 low-income patients with hyperglycemia over 13 weeks. And just with that small bolus of cash, they actually found a 0.7% decline in A1C. These programs also appear to be quite cost effective. And one recent modeling study indicated that if there was a national subsidized healthy food prescription program rolled out across the United States, that would potentially yield a $100 billion cost in the US healthcare system over the lifetime of the beneficiaries. So there's huge potential in these types of programs, but to date, the evidence is limited by all of these various problems, that these are all generally done in small sample sizes. They're usually uncontrolled studies or observational studies. The subsidies were given for a short period, 12 weeks in many cases, up to 16 weeks. And they almost all of them relied on self-reported outcomes. So brief dietary recall screeners or food insecurity screeners. And very few of them actually had objective health outcomes to really hang our hat and say that this is an intervention that will result in improved health for the population. These subsidies often are limited to fruit and vegetables. They're called fruit and vegetable subsidies, but we know that a healthy dietary pattern for people living with diabetes is much more broad than that. It includes whole grain foods and even lean meats and dairy products. And so there isn't really good rationale scientifically or clinically to limit people to only purchasing food or vegetable, or incentivizing them to only buy fruit and vegetables. And we often know that often fruit is, maybe not as healthy as some of those other choices anyway. So there's some problems with the intervention themselves in these studies. And none of these studies looked at the actual effectiveness in terms of change in hard clinical outcomes or cost effectiveness over the longer term. And those are the types of studies that obviously need to be done to convince and sway policymakers to say this is an intervention that we need to scale up and make more widely available. And then very few of these studies have generated or developed knowledge of implementation strategies, or how do we actually make this work in our communities and in our clinical practices. So these are some of the knowledge gaps that my team was interested in building upon and improving upon. So this is the current situation as we've described it, that household food insecurity leads to a reduction in diet quality, which impairs people's diabetes self-management ability, leads to higher A1C and cholesterol, blood pressure, BMI, and all of those things we know are contributors to diabetes complications like retinopathy, neuropathy, vasculopathy, etc., which cause acute care use, costs, mortality, and all the bad things that we don't like. So this is the problem we're trying to tackle. And we are postulating that by investing, and currently this is what our healthcare system does, and we do fairly well, as you all know, that we invest downstream. We've got acute care systems that absorb the vast majority of their healthcare dollars to treat the complications of chronic conditions like diabetes, with very minor investment from our healthcare system in the upstream determinants of health. And that's the type of shift that we are trying to work on, is that by investing upstream, and we've calculated the cost of this program being potentially about $1,400 per patient per year, that we could improve diet quality and all these things. The arrows flip essentially, so that we can reduce complications and acute care costs. And by so doing, we've calculated that we could avert $10,000 per patient per year. So in my mind, the math is pretty clear that it makes sense to invest upstream to save tenfold downstream, but we need the evidence to be able to support this claim and to be able to push governments and stakeholders to invest in this. And that's where our study comes in. Our study is called FoodRx, and I'm going to walk you through our study protocol, and if you wanted further information, you can find it here, published in the BMJ Open last year. But the objective of our study were to examine the reach, effectiveness, adoption, implementations, and maintenance, so we call that the RE-AIM, of a healthy food prescription incentive program for patients experiencing food insecurity and with hyperglycemia, or blood sugar levels that are marginal at best. And so we're doing this in three ways to try to counter all those limitations I told you of the existing literature. Our objectives are to conduct a randomized controlled trial with an implementation study to really understand how this might be implemented and scaled, and also to conduct a modeling study where we'll better understand the long-term implications and health outcomes of this program. And we're also working with our colleagues in health economics to model out the costs associated with these programs, both the costs of running the program and how that might be offset by the cost savings that are generated from improved health outcomes. So I'm going to spend most of the time talking about the randomized controlled trial and how we're assessing this effectiveness domain of RE-AIM. So we're currently recruiting participants in the province of Alberta whose age is between 18 and 85 years, who have diabetes with an A1C of 7 to 12%, and who are food insecure, or who have perceived income adequacy that is self-reported. Because there's a number of surveys and other things that need to be done, we are looking for people who either can communicate in English themselves or have a family member or somebody who can help translate and interpret for them. We're excluding a number of people, as did here, notably people who are pregnant or breastfeeding or trying to conceive, people who are in other clinical trials, or people who don't live within 100 kilometers of our participating supermarket, which is Loblaws, Superstore, No Frills, etc. The intervention that's being provided through our program is being provided in a randomized fashion as an RCT. And so we're randomizing 594 adults with diabetes and food insecurity to one of these two groups. The comparison group, or the control group, is a healthy food prescription group. So they receive just the healthy food prescription. And the intervention group receives the healthy food prescription as well as an incentive to purchase healthy foods, which is a financial incentive, which is at $1.50 per day per household member. And it's being provided actually for 12 months. We've extended the study now out to 12 months. And so I'll talk more about what these interventions entail in a moment, but I think it's important to know what the outcomes are. What are we actually studying and what are we hoping to see a difference in? And so our primary outcome is A1C. We're going to measure a number of other secondary clinical outcomes, such as blood lipids and blood pressure and BMI. We're going to follow dietary outcomes, both self-reported diet quality, as well as the carotenoid levels measured through the transdermal skin scanner to actually have an objective measure of fruit and vegetable intake, as well as a number of patient-reported outcomes to try to get a sense of whether this program actually helps people feel better and feel less diabetes distress and more empowered to manage their diabetes, as well as what it does to their food security, which is self-reported as well. So just to show you what our healthy food prescription looks like, this is provided to all participants in our trial, both in the intervention and in the control group, where people are provided with this brief diet counseling, and it's meant to be provided by a healthcare provider of some sort, and we have a nurse as well as a dietitian on our team that provide this, and it's really meant to be standardizing and replicating routine clinical care. And so this is not meant to be full-scale diabetes education, but it might be meant to replicate something that you tell your patients in a primary care clinical encounter. Some brochures or leaflets that are provided. Then this is created in consultation with our dietitians as well as our patient partners to be patient-friendly, understandable. And this is the first page, and this is the second page. It's really just a 4-pager. And on the previous page, we have a place where the healthcare provider actually signs the document to say that this was done as a prescription, because we actually know that there is something unique about a written prescription from a healthcare provider for patients' perception that is quite different from patients reading a pamphlet that they may find or be handed. And so this is the healthy eating prescription that's provided to all participants in the study, both intervention and control. And for those randomized to the intervention group, in addition, they receive this healthy food incentive. As I mentioned, is $1.50 per day per household member, which doesn't sound like very much, but when you factor that out over time, it's $10.50 per week. And if there's 2 household members, it goes to $21 a week. 4 household members, $42 per week, which can be a sizable increase to people's disposable income and what they have available to help them purchase foods. This is being operationalized through the PC Optimum loyalty program, and people are actually provided these dollars in the form of PC Optimum points on a weekly basis. And how do we come to, we often get asked, how did you come to this amount? And there was a number of contributors to this. When we looked at Wholesome Wave, which is one of the biggest food prescription programs in the United States, they typically provide 50 cents to $1 a day per household member. So we said, we probably need to go more than that because it's more expensive to live and eat in Canada. And so we went to $1.50 a day. Many of the studies average around $40 a month. And so we wanted that to be the lowest that we would use for a single person household. We also wanted to not provide anything less than what is provided as a dietary supplement through Sure Alberta Works, which is currently $41 per adult per month. And we found there are a number of studies that suggest that the gap in spending for food insecure and food secure households ranges between $30 and $60. And so a two to three person household would nearly bridge that gap at our current subsidy level. So that's our rationale for having done this. And let me just show you briefly how this works, or how people are able to redeem or accumulate these points, which are as good as dollars. So right off the bat, in week one, people are provided with a dollar value based on what they qualify for based on their household size. So a single family would receive that 10 and 50 right off the bat of points straight into their PC Optimum account. If people use either those points or their own money in that ensuing week to buy eligible healthy foods, they can earn back the same amount that they're eligible for every week. And so by spending the $10 on eligible items, this participant receives another $10, which then in week two, they're able to go back to the grocery store and spend again, and continue the cycle essentially. So in week three, they select $10 worth of eligible items, they pay for these, and then they earn their points for the following week. And so it's meant to be both a financial intervention that it gives people free money, as well as a behavioral intervention that it pushes people or challenges them to buy healthy foods from our healthy food list. And this was generated in conjunction with our study dietitians to include not just the fruits and vegetables that are more traditionally included, but also a number of other foods that we deem to be healthy or in keeping with best practices and recommendations for a diabetes-friendly diet. So fresh meat, poultry, and fish, meat alternatives, dairy products, whole grains, and what you will not find here is anything that is processed or has added sugars, salts, or fat. And so these are the foods that we know that patients with diabetes, and really all of us, should be eating more of. And through our program, we're hoping to incentivize people to make those healthy choices. So this is from the patient-facing materials and brochures that we provide to help them learn what is and is not included. And so, there's a whole fancy booklet that we put together, lots of pages that we send patients to help them feel empowered at the grocery store to know which items are and are not covered by their subsidy. So these are things that are covered, and then we provide some examples of things that are not covered as well on other pages. But these are the types of educational materials that go along with our study. So to date, our study has recruited nearly half of the 594 participants that we were looking for. And we were very eagerly looking for new participants to join our study. And so I wanted to spend a few moments telling you about how does someone get into our study, and how can you potentially, as primary care providers and as healthcare providers in the province, help us get people into this study that will hopefully help make this intervention a reality for many more people beyond the clinical trial phase. So I think it's important to first state that our recruitment pathways have changed dramatically over the course of the last couple of years since we started this study. We actually initially conceived of this study in the pre-COVID era. And at that time, we figured that our best bet for recruiting people working directly with primary care clinics and actually going into clinics and having clinics help us with baseline measures and blood pressure and weight and all of those things. And we found a number of clinics across the province who were willing to partner with us on this in the fall of 2019. And we all know what happened after that. And clinics' attention was rightly and reasonably directed elsewhere. And so we had to broaden our recruitment pathways in the ways that we would about finding participants for our study. So nowadays, primary care clinics are our greatest ally, but we are requiring much less of clinics that help us to recruit. Where now, essentially, we're just asking that clinics and clinicians and MOAs and nurses in clinics just share the information with patients. And we have a number of ways that information can be shared. We have a website that's up, which is foodrxalberta.ca, and participants can self-refer by clicking participate now. We've got posters and brochures and information slips that are available. to be printed or to be sent to you in printed format that you could hang up in your clinic waiting rooms and in your and in actual clinic rooms. And we're finding that these are some of the most valuable ways that patients are finding out about the study. And we really recommend, highlighting the benefits to patients of being in this study. Not only is a randomized trial and the chance of receiving the food incentive for the full year, which is a pretty enticing offer, but we're also paying people $300 for completing all of the data collection elements of the study. So that's doing baseline data collection and 6-month and 12-month follow-ups. So we're compensating people for their time, and that's seeming to get people interested in participating. So we would love if any of you out there listening to this live or the recorded version are interested in helping us recruit patients. We would be thrilled to work with you and partner with you. And I've got my contact information at the end of the presentation that I'd be happy to share, and would be happy to email you these materials or print them and mail them to you, whatever works best in your situation. I think it's important that what happens after patients contact us. So interested patients will complete an eligibility survey, and they can either do that online through our website, or they can contact us to complete their eligibility screen. And our team really takes it from there. Once eligible patients complete their informed consent, they enroll into our study. And after enrollment, this is essentially what the study looks like. So at the starting point, patients complete surveys that are done preferably online, but can be done via paper or telephone, about their health and their dietary patterns. There is a baseline blood and urine test for us to be able to measure our hard clinical outcomes. We actually need a standardized A1C, ACR, lipid profile, etc. And we need physical measures that are completed, like height and weight. And for this reason, because we require all of this data collection, we're primarily recruiting from Calgary and Edmonton at the present moment, because we have study data collection sites in the 2 major cities where patients can come. We book them into an appointment with our study team nurses. And then when they come, we get all of their physical measures done. So we have had a few outreach clinics and programs in rural parts of the province, but for now, because of the logistics involved, we're trying to focus our recruitment on Calgary and Edmonton. Once patients are randomized into a group, they're followed, obviously, for 1 year and beyond. So at 6 months, there's another repeat survey that's sent out, as well as an A1C. And at 12 months, we repeat the whole battery of assessments, including the surveys, the blood, the urine, and the physical measures, which are repeated at 12 months. And at 18 months, again, we are repeating surveys and A1Cs to see whether the intervention was durable or had lasting effects after the intervention was completed. So 4 data collection points. And people receive $100 for the starting and the 12-month follow-up, and $50 each for the 6-month and 18-month follow-up. And so patients can receive up to $300 by completing all of the data collection steps. And that's for people both in the intervention as well as the control group. So I also would like to let you know a little bit about a study that we just completed, where we actually wanted to find out what patients were saying about this intervention and what is their impression of this. And so we did a study. My master's student recently completed this study, where we actually looked into acceptability of the intervention, and prospective acceptability is what we were looking at. So that's people's anticipatory acceptability. What would they think about the program not having done it or completed it yet? And this refers to their emotional and cognitive response to the program prior to using it. And it can provide insight into future engagement and adherence and changes that could be made to help people be more engaged. And so we completed semi-structured interviews to explore this prospective acceptability. And we interviewed 10 people who wanted to participate but were ineligible to, because their A1C was out of our range. And another 5 people who heard about the trial and expressed initial interest. When they found out more, they decided not to proceed. And so we interviewed 15 people total for this program. We wanted to have that breadth of perspectives represented to find out what people would think about this. And so people who wanted to use the incentive thought that it was straightforward. They loved the stores that we were working with and appreciated the variety that we're providing on our eligible food list. They anticipated that it would reduce possible experiences of stigma, that unlike food stamps or some other program where people feel stigmatized, they thought that our program would not be that way. and they anticipated a positive impact on their diabetes management and diabetes control. So that group was fairly easy they were already interested and invested, and they told us that they really loved the program and were interested. The other group who decided not to proceed or not to use the intervention gave us some interesting information that we're now considering how we implement it. They were less confident that they could use the incentive successfully, and they felt they would need practice using it. So we built in more practice modules and training to help overcome this barrier, including extensive training materials with booklets and videos and training phone calls with RAs. We have a study helpline that's available, as well as email to help patients address their questions and concerns. We review use on our end on a monthly basis to see whether people are using incentive or not. The other big feedback we received is that some people didn't like our partnering store. It wasn't the store of their choice, and they didn't really like the specific brands that were on our food list. And so they said that it's hard for us to get to those particular stores sometimes, and that might be one of the reasons that we're not going to do this. And so we're presently looking at the possibility of expanding the number of stores or the eligible items for the program, either in this trial or beyond. So these are the types of things that we're trying to do. So in conclusion, we heard that all participants strongly believed that the food restrictions were a good thing, and that the earning feature of the incentive was positive and would help people with their diabetes management. So there's more I could say about the other parts of the study, the modeling study, as well as the implementation study, but I'll stop here and just go to my last slide, which has our contact information, and just thank you for listening tonight. And we would really love your help to help get your patients into our study. And we think that there's benefits for your patients proximally in terms of their own diabetes food security if they're randomized to the intervention group, as well as tremendous potential and possibility to improve the state of food security and our ability to really give us another tool in our armamentarium of healthcare providers of what we can do to address these very challenging social needs that right now are not being well addressed by our current system. And so if you can help us, we would be thrilled. You can either reach out to myself directly or to our study coordinator, Terry Saunders-Smith, and we'd be happy to get you set up with anything you need, answer any other questions that you have, or send you recruitment materials to help advertise the study to your patient population. So with that, I will stop and happy to take any questions. I guess I'll back over to you, Rose.
Thank you very much, Dave. That was a really enlightening but also sobering presentation, but also very exciting that you are doing work to address this very important gap. So I have a couple questions to start us off. So number one, do you know why Alberta is particularly worse affected by food insecurity? Because previously, when I've looked at the StatsCan data or the administrative data, income is higher in Alberta on average, at least historically. But has this been, a shift in the recent couple of years?
Yeah, great question, Rose. I think there's some ongoing work right now to try to figure out why that is the case, because that has not historically been the case. I think if you look historically, Alberta tends to sit in the middle of the pack for food insecurity prevalence. And we've often thought that incomes tend to be higher here, and cost of living is actually more reasonable here than places like Toronto or Vancouver. And so, traditionally we've been buffered or protected by those things. We don't know exactly why, but part of the problem here is that inflation has really dramatically played a role, and that people that live in more rural communities tend to be more affected by food insecurity or by inflation and food price increases. And because we have a sizable proportion of our population that live in not necessarily rural but smaller communities, Lethbridge, Medicine Hat, Fort McMurray, Grand Prairie, those places where the food is even more expensive than what we might see in the bigger cities, whereas some of the other provinces tend to be more concentrated in bigger urban centers. That might be part of the reason. but it's also a matter of the macroeconomic things that are at play, that we know that, the last 5 years in Alberta have not been as kind to Albertans as before. And hopefully our fortunes are on the upswing with the price of oil changing, which we know is very, very much plays a role in everything in Alberta. All the studies that I do on homelessness, we see that when the price of oil goes down, homelessness rates go up. And I think likely what we're seeing is hopefully the tail end of that 2015 bust cycle in the oil and gas industry. And there are a lot more people that were unemployed. And we actually know that we actually still sit above the national curve for unemployment. As Albertans, we're not used to having that unpleasant distinction, but I think that's a big thing, that unemployment is higher here than it's traditionally been.
Thanks. And so I have another question with regard to the healthy eating prescription that you showed the picture of the suggestions, and to avoid, excess fats, and to eat 3 meals a day. Given the popularity and actually the endorsement and evidence surrounding things like lower carb eating, ways of eating, and intermittent fasting is gaining increasing evidence in the world of metabolic disease. How do you reconcile that with the current way that eating prescription is, and what are your thoughts on that?
Yeah, great question. So you're absolutely right that there are many different takes on healthy diets and appropriate diets for diabetes. What we tried to do here is go with what the tried and true, kind of what the clinical practice guidelines currently say in Canada. And so a lot of that was taken from the Diabetes Canada CPGs from 2018, which is the last big update that we had. But since that time, Rose, as you mentioned, there's been a lot of evidence that are suggesting that alternative patterns of eating actually may be even better for metabolic control. And so since that was not the focus of this study, we wanted to really see the incremental difference between those who got the incentive and those who did not get the incentive. We decided to kind of stick with the party line, if you will. But I certainly hear what you're saying, and I agree that there's a lot of promise in dietary approaches that are not the traditional approach to diabetes. So the future iterations of this program may need to change what that prescription is, but because really the focus on this was to say, what is the incremental impact of that prescription, of the incentive? We've tried to kind of keep the prescription low key, if you will, that we were hoping that not to be a major driver in people's behavior change.
Thanks. Yeah, well, I know the 2018 guidelines did discuss low carb eating. So yeah, I think it's people. I'm getting a lot of people confused in clinic about what to do. So it's definitely an issue around messaging, because people are afraid to eat eggs, and they're afraid to eat higher fat dairy. And so if people have diabetes, have to there's a lot of, I guess, unlearning or debunking a lot of the evidence or so-called evidence that has now been proven to be substandard and outdated. So
absolutely.
Are there
that is that's one of the, so our program really focuses on no salt, sugar, or fat. So we did include eggs, and we include all milk. So we didn't limit it to low fat percent of milk. So that was something we did consider. It's just we wanted to make sure that we weren't pushing people to make those types of choices, and that we know are not evidence-based. So there may be additional things, but at least we're hoping to kind of keep it
it's a
relatively
good start.
evidence-based.
It's a good start.
Yeah, exactly. Yeah.
Are there any questions out there in the audience land? I haven't seen any on my chat box, but probably because this is really exciting and you gave a very nice overview. I wonder, with the political situation in Alberta, I also think hopefully there is opportunity for change, for better change. Fingers crossed.
Yeah, it's always a challenge, but our hope is that by everyone's interested in saving money. It doesn't matter what political stripe you come from. That if we can show that there's the possibility to avert adverse outcomes, and with that save money, we're hoping that we're able to get some traction with whoever is in government at the time.
Yes, I think the concept of food as medicine, I think, is very welcome in a lot of the general public spheres. And so hopefully it will resonate with policymakers. And I'm trying my best to find people. And I wish the study was open to those with gestational diabetes, particularly diabetes in pregnancy. My patients with type 1 diabetes often have the same issues because a lot of them end up having metabolic syndrome because of the issues with the vicious cycle of insulin and weight gain. And so maybe you've got a partner here if you want to expand.
Amazing. I love it, Rose. Well, FoodRx 2.0.
Yes, on board.
Excellent.
Well, on that note, maybe we'll give people a little bit time back in their schedule if there's no questions. And once again, please give us your feedback on this chat, and also let us know what future topics are of interest to you. So within the Office of Lifelong Learning, we really want to meet your learning needs. So please do let us know what you're interested in. And thank you so much, Dave, for joining us tonight. I hope we get the word out there. And everybody, please spread the word. We will be sending out the recording as well as materials pertaining to the study. So you can let your colleagues and patients know. And oh, my other question. Did you partner with the pharmacies and clinics located within, the company's stores?
Yes. Yeah. So the clinics are operated kind of independently of the store, but yes, the pharmacies absolutely. So you will find our recruitment materials at the pharmacies that are located within the Loblaw stores, and they're affiliated with Shoppers Drug Mart. So they've been helping us as well. So that's our next wave of recruitment that is just going out now, is really trying to push through the pharmacies, not just those pharmacies, but pharmacies more generally as well, as we know that that's a place where all of our patients go and they see their pharmacists, certainly more than they see me, and I'm sure more than they see me, their primary care physicians as well. So yes, absolutely, the pharmacies are our next next target, but we still need our physician colleagues to help out.
Clinical colleagues. I was just thinking, hopefully they'll put up the signs right by the coupons, at the front.
Yes, exactly. Yes, good idea. That's a great suggestion.
Okay, well, all the best, and look forward to seeing what comes of the study. So maybe we'll have you back for that.
Sounds great. Thanks, Rose. Thank you, everybody.
Okay, take care, everyone. Have a good night. Bye-bye.